Good morning, everyone. Welcome to the spring workshop of the Roundtable on Population Health Improvement. I'm Ray Baxter. I'm a trustee of the Blue Shield of California Foundation and a member of the board of directors of the CDC Foundation. And I am the co-chair of the Roundtable on Population Health Improvement, which is housed within the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine. I welcome all of you in the virtual audience today, as well as those of you who are viewing the recorded webcast of our workshop entitled U.S. Healthcare Expenditures, Costs, Lessons, and Opportunities. Although this is a virtual workshop, it is being hosted from a physical location in Washington, D.C., the home of the National Academies and the Roundtable. Everywhere in the United States, where our speakers and attendees find themselves at this moment, we are on the lands of Native American tribes and peoples. And for that reason, we would like to acknowledge and offer our deep gratitude and respect to the Nacotchtank and Piscataway people and elders and ancestors, past, present, and future. We lift up all of the ancestors who have struggled for justice. And in their memory, we seek to help build a just future by centering health equity as the prerequisite to improving population health. Our roundtable recognizes that health and quality of life for all are shaped by interdependent historical and contemporary factors. These include social, political, economic, environmental, genetic, behavioral factors, and healthcare itself. Therefore, the roundtable seeks to catalyze urgently needed multi-sector, community-engaged, collaborative action to address these issues. One way we do this is by hosting several public workshops each year. These workshops bring together different perspectives, disciplines, and sectors to explore what works to improve the conditions for equitable health and well-being. A few words about the rationale for this particular workshop on healthcare spending. This roundtable has not been focused on healthcare reform or healthcare finance specifically, but healthcare spending is integral to conversations about the social determinants of health and the well-being of communities. Healthcare spending shapes our economy. It affects the economics of families, and it can limit public and private investment in childcare and education and housing and other essentials. It may even reinforce some of the structural inequities that shape people's health and well-being. So healthcare spending does matter to population health. In September of 2019, one of the roundtable's chairs at the time, Sandy Magnan, who's here with us this morning, worked with a few members and other colleagues to launch the Healthcare Expenditure Collaborative to explore this problem. They looked at the opportunity costs, the solutions available, and the misconceptions people have about the relationship between healthcare and health. Despite devoting 1/6 of our economy to the healthcare system, our nation's health ranks as poor compared to other wealthy OECD nations. In 2013, the National Academies released two compelling reports. The first report, For the Public's Health, Investing in a Healthier Future, recommended the Secretary of Health set 2030 targets for life expectancy and for healthcare spending to bring the U.S. in line with comparable nations. The second report, U.S. Health and International Perspective, Shorter Lives, Poorer Health, made the case that the U.S. does not achieve long, healthy, and equitable life expectancy for a number of reasons, including structural problems that create unequal life chances for people. And the results, the report argued, cost lives and dollars. These reports really formed a foundation for today's discussion. Nearly a decade later, these problems persist. U.S. life expectancy is indeed decreasing, and the pandemic has cost the lives of more than 500,000 Americans now. This weekend marked two anniversaries. the shutdowns that marked widespread acknowledgement of the pandemic a year ago, and the killing by police of Breonna Taylor. COVID-19 has brought everything, including our failure to invest in prevention and preparedness, into sharper focus. And the struggle for social justice has forced us to look deep into the stark inequity with which the pandemic has hit our people. Today's workshop was organized by a planning committee chaired by Sandy Magnan, and including Rachel Block, Adam Bress, Mark Gurevich, Meg Guerin-Calvert, Dora Hughes, Eric Schneider, Kosali Simon, and Lauren Taylor. The planning committee was supported by our roundtable staff, Alina Bashu, Asia Coltrane, Harika Dyer, and Ali Andrade. We are looking forward to a great 2 days with you and our terrific array of presenters and panelists. If you're tweeting today, please follow @NASEM_health and follow the conversation by using the hashtag #PopHealthRT. Now it's my pleasure to introduce my friend and great colleague, Sandy Magnan. I am so delighted to welcome back Sandy Magnan, who just stepped down as Roundtable co-chair at the end of 2020 after a great run. Sandy is a senior fellow at Health Partners Institute and an adjunct assistant professor at the University of Minnesota. Sandy led the planning process for this workshop. Sandy, welcome back to the roundtable. We miss your regular presence, but we're delighted you can be with us here today. Let me start off by asking you, from your perspective, why is this the time for this workshop?
Thank you, Ray, and thanks for the invitation back. Ray, it is agonizing to watch what is happening to health in our country and to health of populations. You've already mentioned some of them, the over 500,000 deaths from COVID, the racial, ethnic, and social inequities, the racism that's been laid bare in the last year, the life expectancy in our country that is not commensurate with all the healthcare spending that we do. We spend the most of any country in the world. And let's just take one example, infant mortality. We rank 33rd out of 36 countries. And that means that we are just a little bit better than Turkey and Chile and Mexico. And that's not even mentioning that within our own country, African American babies die at twice the rate that whites do. And we also, because of the COVID illustration, we've not been investing in public health. So our infrastructure was not up to the challenge of a global pandemic. So all in all, this is appalling, Ray, for not only on a national stage, but an international stage of what the health looks like in our country. We are not investing in what makes us healthy.
So you've laid out the problem. Why should people in population health and public health care about what's going on in health care? Isn't that someone else's job?
You could say that, but I think this workshop today would argue that certainly within population health and public health, it's also our job to be concerned. I want to clarify that when we talk about healthcare expenditures, that we're not talking about health expenditures. We're talking about spending on medical and clinical services, not the full scope of the factors that make a population healthy. Right now, there is little incentive in the healthcare industry for it to decrease its growth that outpaces inflation and outpaces what other countries' growth is. For example, in 1970, the US spent about 6% of its GDP on healthcare compared to other similar countries. In 2019, the US was spending over 17% of its GDP on healthcare. That gap had significantly widened. The closest to us is Switzerland, who is at 12%. So there's little incentive to address that increasing share of GDP and little incentive to address the estimated 25 to 30% of waste that is in healthcare.
So you could see, though, how people would say, well, everything's changed now. The pandemic changed everything. Don't we need to spend more on healthcare to address some of these problems? What are the implications of rising healthcare costs and waste for health?
I think that is one of my fears. That's one of the fears of the Healthcare Expenditure Collaborative. That's one of the fears of many people, is that we will not look at the opportunity cost. And I like to think about opportunity costs. I'm sure there's an economic definition, but it's benefits foregone. When we're looking at putting more into healthcare, and there are places that we should put more into healthcare, such as the opioid crisis and dealing with public health. There are places we should put more, but there are other places we are foregoing benefits, the opportunity costs, because we spend so much in healthcare in wasted administrative costs and high prices or unnecessary care. And so therefore, we don't have money to use in education, affordable housing, a number of things that you mentioned that overall contribute more to our health than just another test or procedure in healthcare for populations. I like a tweet that Chris Kohler said in this past week. Chris Kohler, who's from the Milbank Memorial Fund, he said about an initiative they started, the Peterson Milbank Program for Sustainable Healthcare Spending. They just announced it. He tweeted, "Why are we doing this work? Healthcare is the tapeworm of the US economy." And he quoted Warren Buffett. And I would add, it's a tapeworm on equitable health and well-being also.
Anna, you and a number of colleagues recently published a whole special section in the American Journal of Public Health called Changing the Health Story, Reducing Wasteful Medical Care Spending. How does that relate to our workshop today?
You know, part of that special section was to continue what you talked about, the IOM report for the public's health that said we ought to set targets on life expectancy and healthcare expenditures to bring us to average, to bring us to parity with other OECD countries, other comparable countries around the world. It wasn't to make us number one, it was just to get us to average. That's how far away we are. So our first publication within that special section was really looking at what will it take. David Kindig and colleagues in 2018 had published what would it take to get to life expectancy. Colleagues at Arizona State University, UCLA, David Kindig, we published what would it take to get to parity with healthcare expenditures. And it's going to be challenging to get to parity, but there's no time better than now to start looking at that. We'll have the links to those up on the Roundtable's website and the Healthcare Expenditure Collaborative website.
Great. So required reading as preparation for a follow-up to our workshop in the next couple of days. Now, not to drill down too deeply as we're just introducing the topic, but you said a couple of times, you used the term per capita healthcare expenditures, setting a target for that, achieving a target for that. Why is that particular framing important?
That's a good question, Ray. And that is what that 2012 report said, to set a target on per capita healthcare expenditures. Measuring that is important because if we can decrease per capita, per person spending, we can provide coverage for more people, as well as have money left over to invest in some of the upstream issues that make us healthy. I know some people in population health and public health don't necessarily like to talk about healthcare expenditures, I think because they fear we won't cover people, we won't provide that universal coverage that we need. But it's actually the opposite is true, that accessibility is related to affordability. As affordability goes down, accessibility goes down. So we need to be paying attention to both.
So what this comes down to, it sounds like you're saying, is we need to pull out those dollars associated with excess spending that aren't bringing value and use those in a way that brings more value for people's health. Is that the bottom line here?
Yeah, yes, I think that's a great way to say it. Sometimes people get worried about the word value and what does that mean, but it's exactly what you're saying. We need to take out wasteful medical care spending that doesn't contribute to improve health and well-being, and actually get it upstream to where we can invest for better results and better population health for all people.
So, Sandy, you and the planning committee have assembled an incredible array of scholars and practitioners for the next 2 days to chew on this topic, tell us what they know, provoke us, share what seems to be working. What's the planning committee's hope for what will come out of these 2 days?
Thank you. Just to remind people of what we do hope to achieve is, first, that this issue of opportunity cost, we'll get a chance to delve into what are the benefits foregone, what are we missing by not addressing it. So we'll really begin to understand that, and will give us as practitioners incentives to say we do need to be helping colleagues address this. Second, there's not enough attention being paid to innovations that are occurring, such as the Milbank initiative with Peterson to address sustainable healthcare spending. Third is we've been trying to do this for decades, and yet what will make it different this time around? What will make it more achievable this time? What's the narrative that needs to change? So that's the third objective. Fourth is, how do we think differently about these investments that we need to accomplish? What research is needed to help us prioritize investments for equitable health and well-being? So we're not going to be tackling in-depth ideas about how to address administrative waste or excessive prices or fraud and abuse in healthcare, but we will be elevating the why of this conversation. Why should we be addressing this, addressing the tapeworm, as Chris Kohler said? And it really is, as you said, about every wasteful dollar spent in healthcare is not providing value. It's one less dollar for public health, one less dollar for education, one less dollar for universal coverage, for early childhood education, for job development and livable wages. Examples of missed opportunities for equitable health and well-being.
Okay, any last thoughts you want to leave us with, Sandy, before we kick into the program?
Last thought was that David Cutler last week published in JAMA Forum a short piece called "Building Healthcare Better Means Reining in Cost." And it's something that we need to tread carefully to do, he said, but he ended with this, and I quote, "The Biden administration is putting all resources possible into the fight against COVID-19, something everyone hopes is successful. But that is not the only healthcare challenge that the administration will need to tackle. It should devote just as many resources to lowering unnecessary spending on medical care. Doing so is among the most important steps the new administration can take to promote widespread economic prosperity." That's the end of the quote. So we hope our workshop today continues to elevate that discussion and action towards health, well-being, and prosperity for all residents in the United States. Thank you to the audience, and Ray, to you for having us here today in the roundtable.
Well, thank you, Sandy. Thanks for all your service as a co-chair of the roundtable and for chairing this planning committee and assembling this great lineup we are now going to turn to today.